In this video, we'll be going over adrenal pathology. To understand adrenal pathology, we first have to understand the physiology. The hypothalamus is the control center which regulates a lot of body's hormones. One such hormone is corticotropic releasing hormone. The corticotropic releasing hormone is released by the hypothalamus into the hypophyseal portal system. It travels through the hypophyseal portal system into the anterior pituitary and stimulates the production of pro-opiomelanocorins. Pro-opiomelanocorin is a polypeptide around 300 amino acids long. It is cleaved into three separate hormones, one being ACTH, another being melanocyte stimulating hormone, and another being beta endorphins. ACTH then enters the bloodstream and travels through the adrenal glands to stimulate the production of steroid hormone synthesis. Steroid hormones are produced from cholesterol. Cholesterol is usually present in the cytosol and it needs to enter the mitochondria in order to undergo steroid hormone production. Cholesterol enters the mitochondria using the carrier protein, steroidogenic acute regulatory protein, also known as STAR. This is also the rate-limiting step for steroid hormone production. Once it's in the mitochondria, cholesterol undergoes a reaction with desmolase, which is under the control of ACTH. Desmolase converts cholesterol into progenolone, which can undergo mineralocorticoid pathway in the zona glomerulosa or the glucocorticoid pathway in the zona fasciculata, and the sex hormone pathway in the zona reticularis. The mineralocorticoid pathway results in the production of aldosterone. Aldosterone is mostly under the regulation of the renin-angiotensin-aldosterone axis. Aldosterone works on the distal convoluted tubules on the principal cells and the alpha intercalated cells. It acts to reabsorb sodium and secrete potassium, thereby increasing passive reabsorption of water. It also acts to secrete protons and reabsorb bicarb and secrete chloride. Therefore, it can be a reason for metabolic alkalosis and hypertension if you have it in excess. Glucocorticoid pathway results in the production of cortisol, which is a stress hormone. It causes increases in blood pressure by upregulating alpha 1 receptors in the arterioles. It causes increased insulin resistance, increased gluconeogenesis, lipolysis, and proteolysis. This is due to the fact that cortisol during stress it increases the amount of glucose that's available for the brain. And for the peripheral body, it prefers that it use fatty acids and protein metabolism for energy, since glucose is more important for the brain. It also decreases fibroblast activity, which leads to increased time for wound healing and decreased inflammatory and immune response. And your sex hormones, the testosterone and the estrogens, are involved in secondary sex characteristic development and puberty. There are certain enzyme deficiencies that show up on the USMLE Step 1, Step 2, and Step 3. The most common ones are 17 alpha hydroxylase deficiency, 21 beta hydroxylase deficiency, and 11 beta hydroxylase deficiency, all of which are most commonly autosomal recessive. 17 alpha hydroxylase deficiency results in the knockout of your glucocorticoid pathway and your sex hormone pathway, and it leads to increased production of aldosterone. Increased aldosterone causes hypertension, hypernatremia, hypokalemia, and can cause metabolic alkalosis. Also, the knockout of the glucocorticoid pathway, mainly cortisol, results in patients being hypoglycemic since they won't be able to undergo gluconeogenesis in times of stress. Also, the knockout of the sex hormone pathway will result in ambiguous genitalia in boys, since you will not have any testosterone, which leads to secondary sexual characteristics. In 21 beta hydroxylase, you have deficiency in producing mineralocorticoids and glucocorticoids, so all of the precursors from the steroid hormone pathway, the progesterone and the progesterone, are shunted towards sex hormone production. Therefore, these patients will be hypotensive, hypoglycemic, and they will have ambiguous genitalia, especially in girls. In 11-beta hydroxylase deficiency, you'll have the precursors of mineralocorticoids and glucocorticoids, and you'll have sex hormone production, but you will not have aldosterone and cortisol. Therefore, the negative feedback will not be as effective, so you'll have upregulation of ACTH causing buildup of mineralocorticoids and glucocorticoid precursors. The buildup of mineralocorticoid precursors will cause them to be hypertensive and hypokalemic. And because you don't have aldosterone cortisol, and buildup of these precursors will be shunted towards the sex hormone production, which will lead to increased testosterone. Increased testosterone in girls will cause virilization and result in ambiguous genitalia. Adrenal insufficiency is defined as loss of adrenal gland function. It can be separated into primary versus secondary. Primary is due to the adrenal gland itself not producing the hormones that it produces, and that can be acute or chronic. Acute is usually due to a large hemorrhage, which causes decreased perfusion to your adrenal glands, causing acute hypoxic injury. Chronic is going to be an autoimmune disease, mostly in the Western world, and TB related in the developing world. On the boards, it's also associated with Neisseria meningitidis, DIC, and endotoxic shock. Secondary adrenal insufficiency is decreased production of ACTH by the pituitary, which can be caused by a pituitary adenoma, which is silent or either producing a different hormone and causing a mass effect and causing decreased production of all other pituitary hormones. In this case, you'll have preserved aldosterone function because of the renin-angiotensin system. The renin controls the aldosterone secretion from the adrenal glands, and you'll have no hyperpigmentation as seen with the primary. The reason you see hyperpigmentation with the primary is because you have increased secretion of ACTH. And remember that ACTH is cleaved from pro-opiomelanocortin, which also creates melanocyte-stimulating hormone. The melanocyte-stimulating hormone causes the hyperpigmentation. Since in secondary it's due to decreased ACTH, you will not have hyperpigmentation. The symptoms in adrenal insufficiency include weight loss, abdominal pain, asthenia, amenorrhea, fatigue, weakness, and poor appetite. On physical exams, patients will complain of muscle tenderness. You'll also observe decreased axillary and pubic hair, and increased pigmentation if it's primary, and no hyperpigmentation if it's secondary. Labs will show hyponatremia and hyperkalemia. That's because you don't have aldosterone in primary adrenal insufficiency, and mild hyperchloremic metabolic acidosis. That's also due to deficiency in aldosterone. The way we come to diagnose primary adrenal insufficiency is by testing morning cortisol with ACTH. Low cortisol and elevated ACTH will be will be diagnostic of primary adrenal insufficiency. And if the lab values are equivocal, you can get an ACTH stimulation test. That is, you give concentropin and see if cortisol increases. If cortisol increases by more than 20 micrograms after 30 or 60 minutes of giving concentropin, that is a normal response. In the etiology of the patient's symptoms, it's likely to be something else. If the cortisol is low after concentropin and ACTH is high, that means the adrenal glands are not producing cortisol as they're supposed to in response to ACTH, and that would point towards primary adrenal insufficiency. If there's low cortisol and there's low ACTH, or there's minimal response to concentropin, that is more likely to be secondary or tertiary adrenal insufficiency. So far, we have covered adrenal insufficiency, which results in decreased production of cortisol due to several factors. Could be autoimmune disease, or it could be infections, or it could be hemorrhage. On the other spectrum, we have Cushing's disease, which is increased cortisol. Cushing's disease is due to a pituitary adenoma that secretes ACTH, in contrast to Cushing's syndrome, which we will not be going over in this video. Cushing's disease, due to pituitary adenoma, upregulating ACTH and then upregulating cortisol production chronically, not in response to stress, causes patients to have weight gain, hypertension, and characteristic findings include moon phases and purple striae with trunk obesity, fat pads on the back, known as buffalo hump, and osteoporosis, insulin resistance causing hyperglycemia, amenorrhea, and immunosuppression. More details on Cushing's disease, the treatment and diagnosis will be discussed in future video. Thank you for watching.